Welcome back to Face It with Dr. G. I'm Dr. G, and I have such a pleasure today to be sitting here virtually with Dr. David Kashan. He is a nationally renowned plastic surgeon that has a fascinating story, including time at the Cleveland Clinic with extensive research. Now he does both face and body, and we're going to talk about some really hot topics that span the plastic surgery world as well as the non-surgical injectable world and how those intersect and why certain treatments are chosen for certain individuals. So welcome.
Thank you so much. I want to say I'm really excited to be a part of this. I've been looking forward to chatting with you for a long time, so I'm glad we finally got some time to sit down and go over some things, and thank you for having me.
Yeah, it was so exciting. So the way we connected was through a mutual friend, Jacqueline. Jacqueline works in your practice. She's awesome. And I had the pleasure of getting to know her at one of my favorite hobbies during cycling. We were at Soul Cycle on the Hamptons when we had our pop-up there. So fast friends, and here we are. So.
Yeah. She's a big fan of yours, and she's been excited for this. If she was in the background right now, she'd be smiling grin ear to ear, but she's running around. But she said great things. So again, very excited to be here.
Yeah. So tell us a little bit about your story and your background to start.
Yeah, originally from New York area, and born and raised in Long Island. After I went into the medical world, I originally started with general surgery at SUNY Downstate, and I was kind of balancing between what I wanted to do at that point. I was in between doing breast oncology, plastic surgery was always high up on the list, cardiothoracic surgery, and I think the benefit of going that path of doing general surgery first is I really got to experience every surgical specialty and then realized where my passion lies. I always wanted to do something, I like the cosmetic side of it, obviously, but I love the reconstructive aspect of it, and it really got me to be able to do both sides of it and still be involved in the cancer side of it, which I really enjoy. And then after 5 short years in Brooklyn, I did a 3-year fellowship at Cleveland Clinic, which was probably one of the absolute greatest experiences of my life. Really trained with some of the greatest surgeons I've ever operated with, and really people that I respect and consider mentors. And when I was done there, I moved back to New York. I was briefly part of a different practice, which again was an excellent experience. And then here we are now. I decided to open up shop now almost 3 years back, and it's no turning back. I've loved every second of it.
There you go. So now it's on to the business ownership part. We could talk all day about that too, and all the hurdles. But I love your story, and I think it's so incredible how when you're in medical school and then in residency, it's not about knowing what you want to do. At least for me, it was let's delete what's not right for me. So you really have to experience everything, figure out, what kind of life you want in the future and what you really don't like. So then it narrows the path.
Correct. I think that's one thing that if I could make a suggestion, if there are any students out there listening to this, just because you went in thinking you 100% wanted to do one thing doesn't mean you can't change your mind. Don't be stubborn about it, essentially. If you asked me when I was a first year, 100% I'm doing breast surgery. You asked me as a third year, 100% I'm doing cardiothoracic, right? And those things change because you change. Like you said, you value things differently, you care more about things. So I think be malleable in your education, absorb all of it, and you see what works best, because this is something you're doing for, hopefully 50 years plus, or whatever your duration of practice is. So you want to make sure it's something you love and not something you're just tolerating.
Absolutely. You gotta love what you do. So one thing that I really wanted to touch on, I think, especially we have a lot of listeners that are in the aesthetic space, and we hear a lot about fat transfer, and it kind of ebbs and flows with respect to how often we hear about it. But I think there are a lot of questions around fat transfer. And I know I have some as well. I know there are some medical aesthetic practices that do fat transfer, as well as the plastic surgeons. Talk to me about the treatment, who's a candidate, everything in between.
Sure. So there's obviously multiple types of fat transfer, and I guess when we're talking about it, we have to separate it between body and face. If we're talking about body, let's say we're talking Brazilian butt lift, things along those lines, or breast, really we're talking about full liposuction, and we're somewhat purifying the fat, but not really that much because it's such a large volume. So the goal is to just get it as pure as possible to be able to inject it as safe as possible. Now, that aside, going into the face, which is really probably the majority of what I'm doing in office right now, probably the number one procedure by far, far is facial fat grafting, which is a different story. You don't need general anesthesia for it. It's done through a tiny incision, usually around the belly button or in a previous C-section, wherever there's fat on the abdomen usually is where we go for it. That is where we use multiple filters and we turn it into this, what we call as globular fat, or basically chunky fat, and turn it into a paste filler nano fat. So it's a nice smooth paste as opposed to it being chunky. And the benefit of that is if you're willing to take the time to process the fat, you'll get a much better result. You're less likely to have chronic swelling, more survival of the fat. So where you're putting it, you're getting 90% plus survival, whereas on the body, you're really looking at about, let's say, 60 to 70% survival of the fat. You're less likely to have irregular contours or bumpiness in the face too. Obviously, these are all very important, and the face is very unforgiving. So if we're going to be injecting, we want to make sure it's accurate and safe. And it has pretty much taken over my practice. I do more fat grafting at this point than I do injectables like fillers and things along those lines.
So I have a couple questions with that. So why is it that I want to talk about the amount of time it takes for processing, and obviously more processing takes more time, specifically for the face. But why does more processing lead to better retention of tissue versus the other?
So it's a great question. So processing is a little bit of a misnomer, but essentially it's going through multiple filters. I actually use and I'm not getting paid to mention them at all, I just really love their product, the Tulip fat grafting.
I knew it. That's the only one I know.
Yeah.
I was like, I wonder. Okay.
It's the best. It's reliable. It's straightforward. It's color coded, which, for us that are just moving kind of quickly, just to have things even color coded while we're going through it, it just makes it more streamlined. Whereas sometimes when you're using a product and you need to use multiple parts, it's hard to discern, the writing on it sometimes is hard to read. Right? This just, I think, makes it much easier. But the idea is that you're creating more surface area. So if the fat is more of a liquid paste, it's touching more of the native tissue in your face. The more contact you have between fat and your normal blood supply, the higher likelihood that the fat is going to survive. So if you really think about it, if you have a sphere of fat, the outside is going to get that blood supply, but the inside, it would take much longer for it to get in there. And that's when you hear about people, really, again, more so in the breast and buttock realm, but where they get oil cysts or fat cysts. It's because the outside survived, but the inside died, so the body creates a wall around it.
Interesting.
Yeah.
So what are the processing times? Is this the same day? Does the patient have to come back while you're still processing the fat?
So it's same day. It's during the same procedure. Fat grafting, depending on how many areas you're doing, specifically facial fat grafting, and also, patient comfort and tolerance and stuff like that, you're looking at about anywhere from 45 minutes to an hour and a half with the processing. The processing being the part that probably takes a little bit longer because the tulip part of it is actually pretty quick. We like to wait before we pass it through the tulip to help separate the fat from all the plasma. So all that blood product and all that stuff. We want to get rid of that. We don't want to inject that because that's the stuff that gets absorbed right away. It'll look great because it'll add volume, but what will happen is 2 days later, you'll lose all that volume, all that plasma you injected.
Yeah, it makes sense. So where are your favorite areas to do fat transfers in the face?
It's an excellent question. So this is probably going to be a hot take for a lot of people, but I am very anti under eye filler. I
agree.
Genuinely hate it. I have never met someone that has had under eye filler that hasn't eventually had some type of complication from it, whether it be chronic swelling, formation of bags, tindling or bluish discoloration of the skin, migration, go down the line. And God forbid, thankfully I've never heard of this happening, but obviously there's the risk of blindness when you're talking about under eye filler. Again, one of the things that you don't have that risk, or there's no documented risk of ever having it with fat grafting. So the difference between the two, I use it for under eye a lot. It's really, really good for someone that just has straight hollowness. So if all they really need is some volume, fat grafting alone will get you there most of the time. If they have baseline bags or protrusion under the eyes, then you're talking to them about doing a lower eyelid lift plus fat grafting. Almost everyone at this point, when I'm doing facial procedures on them, I'm also including fat grafting because A, you're adding that volume back, but also, especially when it comes to the lower eyelid, you're adding support to the lower eyelid. So you're actually lifting the lower eyelid so that it heals nicely.
Yeah, that was my next question was, do you do this in conjunction with blephs? Because I do think there's oftentimes patients want a bleph, but there's that fine line between a very concave, orbital area to make you look older after the procedure. So yeah, that makes sense to me.
Yeah, we've moved, we'll still remove fat, but a lot of the facial aesthetic world has moved away from how can we extract as much fat and volume from the face, and now how can we add volume back into the face. We've realized that facial aging is a loss of that volume, not so much, hey, we have these bags under our eyes, let's just remove it. People, if you look 20, 30 years ago that have had lower blephs, they look very gaunt under their eyes, almost like that skeleton appearance under their eyes. Not that they did anything wrong, because they just didn't have those options then, but we've realized that adding volume back in the right places gives you a nicer result.
Yeah.
And then to kind of go down the other path, cheeks is very common. Around the mouth, nasolabial folds we do a lot of. Temporal, depending on the patient, if they're a good candidate, I love it there as well. And it's kind of, the options are limitless. You could do it in the hand too. People love it in the back of their hand, their earlobes. Yeah.
Okay. Yeah. Okay. I have more questions. So I'm going to be devil's advocate here, because in aesthetic medicine, we hear all about superficial and deep fat pads, from deep fat pads deflate, and the superficial fat pads shift. Essentially, so when we're aging, we get that decrease in volume and the shifting volume. How is it that someone wouldn't say, well, depending on the layer that you're placing the fat, you're adding volume, so I look great right now, but what am I going to look like in 3 years? How long does that fat last? Is that fat now going to be in a place where that's shifting because my bone is decreasing and my deep support is decreasing?
Such a great question. The short answer is there's no real answer to it, but I will say this. There's a way to increase the longevity. And that goes with anything we do. So if we're talking specifically facial fat grafting, facelifts, all of that, to me, it's not just what we can do surgically, it's what we do leading into the surgery and after the surgery. So part of the structural support, in my mind at least, yes, there's the bone, there's the compartments, but there's the skin aspect of it. And if you improve, I'm sure you probably agree with this, but if you improve the skin quality, you're going to overall improve the results long term. So anyone I'm doing facial procedures on now, I really try to get them on a thorough regimen going into it, a skincare regimen. And I think by doing that, to some extent, you're increasing and improving blood supply, so you're getting a better result and retention of fat. I like to do red light therapy. I have red light therapy I send patients home with, and they do it themselves. Again, decreased swelling, improvement in blood supply, inflammation. So by doing that, we're overall improving the results. The caveat to it is if someone decides to lose 20, 30 pounds after they've been fat grafted, there's no saying that you won't lose a lot of that in your face, but we ideally like for you to be at your ideal weight when you're getting these procedures done.
Yeah, that makes sense. So what is, and everyone is different, and I know we don't have a crystal ball. I've been saying that a lot recently. Everyone wants me to tell the future. How long does it typically last on average with a patient that you treat who's in their 40s to 50s?
It's permanent. So that's the real answer. So the permanency of the fat is going to be there. It's not once your body takes it and the blood supply comes in, that fat is there. The difference is you'll continue to age. So it's the same conversation I have with people that we do breast augmentations on. They always ask, well, now you're putting in just an implant, but what about if my breast changes? The implant doesn't move in that scenario. The implant, once it's there, 5, 10 years later, it's in the same position it was when it was first placed, or once it's settled in. Your breast and the skin above it will continue to age. So it's not uncommon that either let's say someone that just got fat grafting, aged out, and now needs a facelift. So we come back, we do the facelift, they say, let's add more fat at that time. But during the facelift, we're repositioning essentially those fat pads anyway. So we're not losing it. It may descend over time, but we're pushing it back up. So it's kind of,
we are still aging, and this is a continuous process that we have to, it's our maintenance, our upkeep. It's
Correct.
Exhausting, but it is what it is.
Correct.
Okay, I have more questions. So there are other products out there that are currently available, one of them specifically where you inject essentially a scaffolding and the fat cells grow in that scaffolding.
Mm-hmm.
What do you think about products like this?
I'm torn. If we're talking about, so there's two things I can think. One is more of a permanent type of filler, semi-permanent. It scares me a little bit to do that because you're injecting something that isn't naturally there at its baseline, and then the worry is what happens when we do come and let's say we are doing a facelift on those people. Did we already distort their anatomy where it's going to be a little bit harder to fix? And then there's the biostimulatory side of stuff, which my issue with that is the unpredictability of the results. We know where we're injecting it, and I know that I'm going to just use the name brand just because it's what I'm using, but Sculptra, for example, we know where we're injecting it. We know that we can make it look good, but you're relying on the body's response moving forward. So to me, it's a little bit more unpredictable. I reserve those for people that really don't have, they really have to have no fat on their body, or they've had multiple rounds of liposuction and they've really burnt a lot of the options for it. One thing I've been intrigued by is they just came out with another version of basically cadaver fat that you can now inject into people. I find that...
Is it Renuva?
Renuva's no longer. I don't know if they're in New York. I knew they are stopped from doing it. I think they're working on getting it back. But it's called it's Alloclay.
Oh, okay.
So it's the same company that owns, it's Tiger Aesthetics, so the same company that owns Sientra and a bunch of the cellulite devices and stuff like that. And they're
essentially the fat cell membranes, right, that are injected, they're purified from cadavers, and then the
Correct.
fat grows within the cell membrane.
Yeah, and they're saying that it's the same retention and it's the same. So basically, you're getting fat grafting without having to do the procedure of harvesting the fat.
But it's not your own.
No, it's not your own. So you run that risk, obviously. Again, it's very preliminary, so they're saying they're not really having those risk of infection and things along those lines. I would use it as a bailout option for someone. So someone that I know really doesn't have any fat that we can really use, needs a decent volume, it's a good option for them.
But I mean, you have the gold standard, so why change?
Correct.
It works. So talk about the downtime and the aftercare associated with the procedure.
Sure. Downtime is very minimal in terms of pain. People take a Tylenol the first day or so, but really, I've never had anyone really past the day ask for anything past they just took one Tylenol or two Tylenol. So pain-wise, you're really not that bad. The real thing is bruising. So especially if you're doing the under eye, you put enough needles in the face, you're going to get bruising. It just is like that with any type of injectable. So just one thing they have to be ready for, they're going to bruise. Some patients bruise more than others. There's a patient we just saw this morning that we did almost a week or so ago. She didn't have a singular bruise on her entire face. I have another patient we did about a month ago. It looked like we punched him in the face a few times. So, everyone's different, but the real recovery of it is no laying on your face for 4 to 6 weeks. That's the real crux of this whole operation. We want to make sure that you're not putting pressure on the fat because we want that new blood supply to come in, and we don't want to essentially choke that blood supply going to the new fat while it's trying to survive. It's fighting for its life in that first month or so, so we want to give it the best chance of survival.
And do you have them take any supplements that help with vascular proliferation or angiogenesis?
I don't.
These new peptides, I don't even know if there's one for that, but any VEGF stimulators, I don't know.
Too soon to determine whether that makes a difference. Honestly, it tends to work really well, and as long as they follow the instructions, they're not smoking, they're not drinking alcohol, they're really kind of keeping to the program. The only things I've ever really added are the red light therapy, which I love. I think it adds minimal risk. And why not introduce it if you're really trying to maximize the results? And specifically for under eye, if they have also darkening of the skin under the eye, or they have a little bit of crepiness, I'll talk about, we could always add on PRP down the line just to inject into the area, just to boost the results. But I'm very clear with it. PRP is a very unreliable thing in terms of you don't know what result you're gonna get. I'm not selling it as a volume booster. I think that's a mistake. That's the same thing to me if you were injecting it as part of a BBL. That goes away in a day or two. It's not gonna improve it the way people say it is, personally. Those are the two add-ons I would do.
Okay. And this may be a touchy subject, but we're here for it. Would you encourage or dissuade physicians who are now in aesthetics, like myself, I'm not sure if this is a procedure that non-MDs or DOs can perform. Would you encourage them to do this in medical aesthetic practices or not?
That's such a great question. I have a bias here. I think
You can be very genuine with your bias.
I think obviously I lean towards the plastic surgery side, with the other side of it being dermatology. So those are the two specialties I think make sense for this. It's when all of a sudden you see dentists doing it and, go down the specialties of people that we see doing it. I believe they're good with their hands, but being good with your hands doesn't replace years of training. Right? It doesn't trade off years of understanding the anatomy, learning the anatomy, being in a cadaver lab, continued education. Everything, when it goes well, everyone's very happy. But when you see the disasters and you say, bad things can happen to us too, right? Complications happen to anyone, and then anyone that's saying they don't have it, they're either not operating enough or they're lying. Those are the two options in my mind. So I think that you need to go to someone that A, knows what they're doing and understands the anatomy, and isn't going to cut corners. That's a big one. And also can handle the potential complications of these procedures, right? At the end of the day, even though we're doing it through tiny pokes, you can cause a lot of harm to people with tiny pokes. Filler being the number one. How often do you hear about someone getting a vascular occlusion? It knocks out their lip, their cheek, their nose, God forbid, blindness. Those are all real risks. You want to be able to go to someone that's going to minimize that as much as possible because they understand the underlying anatomy. And I just don't really see that happening outside of our specialties, realistically.
Yeah, and I totally appreciate and respect and agree with you. I think that's why I've been so heavy in ultrasound and education and teaching myself over the past 3 years of, if we are injecting blindly into faces, it's ridiculous. We need imaging, we need ultrasound. Start with using it for complication management, teach yourself, whatever it may be. But I do hope and pray that in the future it's the gold standard, because I don't understand the concept of injecting without imaging. It doesn't make sense.
Scary.
Or injecting with confirmation and imaging, whatever it may be. But do you see a place for ultrasound with fat transfer at this point in the future?
Not with face. I don't think it makes too much of a difference, because really the concern, at least with ultrasound, is vascular occlusion, and it's too big a particle to cause vascular occlusion in the face. I do see the benefit of it when it comes to butt. I think you see a lot of Brazilian butt lifts. People are starting to really use ultrasound as part of that surgery. And BBLs really did get a bad reputation for people getting complications like death and the blood going to their lungs and causing emboli. So I think in that world, it should be heavily considered. I think the benefit, again, when it comes to face, you don't really have that concern as much, so it becomes a little safer. Could you make the argument that you can directly inject into different fat pads and stuff along those lines? Sure. Yeah, I will never say no to something being safer.
Yeah. Well, I think it's not even about it being safer. That's obviously the key. But then I just had a really great idea, so I don't forget it. It's about my conference. The key is not only just the immediate concern, but it's how do we learn what happens to the product over time? So we're placing it in a certain spot. How do we evaluate? When you're asking these questions, it just is more advancement in the field, which I think is fascinating. This is how we learn that filler doesn't stay where you put it. There's retrograde flow through the needle. It ends up in all the layers. This is why we get all of the clinical effects that we do. But, I think this could be interesting. We have a conference that I started, Face It Live. It's in October in Boston. And I don't know, I have this idea that we may want to have you there to do some ultrasound guided fat transfer.
We could do it. I would be okay with it. Yeah, I mean, again, we would be pushing the limits of things that I'm aware of people doing with it, but I think it would be very interesting.
That's how you have to advance yourself.
Yeah. It wouldn't hurt. How about that?
Yeah.
And that takes me back to kind of what you were asking before. Do I feel like other people should be doing the procedures? And I'll be honest, I haven't used an ultrasound probably now in a few years, but I'm
pick it up like that.
Yeah, correct. I'm heavily trained in between us using it for trauma when I was in general surgery, looking for fluid collections, using it because we're trying to see if someone collapsed their lung. It was a heavy part of my life going up to this. It's just been eliminated a lot because it just isn't as common for what I'm doing now. But that base of knowledge and that training is where it becomes advantageous. I know I can use an ultrasound if necessary, right? So I think that's where you really get that difference. People that have that background can always come back to something that they used elsewhere in their training and be like, hey, maybe we should use this over here, right? Maybe this is a good application for that.
Yeah, and I think that's what's so incredible about our training, right? It's years and years and years of training, years. And I think what's very cool about aesthetics and what drew me to it is just how much everything in my past has overlapped with visual nature, understanding this from a cellular level, obviously the dermatopathology part of it. So it's just this conglomeration of all of these different aspects, which is cool. But people that don't have that, I feel are a little bit more limited unless they really dive into it. So one last question about this, then we'll move on to another topic. Is there anyone that's not a candidate for fat transfer?
For only a fat transfer, really the candidate that I would say I wouldn't do it on is especially for under eye. So someone that already has that fat protrusion, that herniation, I wouldn't only do fat transfer. There's no real person that I would say can't get it in the sense
Like
that
even medically, like clinically and physically, okay? Medically, are there any contraindications?
maybe if they're on a blood thinner, a real blood thinner, I tell them let's stop it for a few days depending on which type of blood thinner. It's not a very bloody operation and it's not a very high risk for bleeding in general. You do, yes, I would want them to not be on blood thinners, obviously, if we're doing that procedure, but that's really it. There's really very minimal, maybe if they have an active infection, so that goes for any surgery. We have a patient that actually is coming up that we were supposed to do a breast augmentation a few months ago, but she had an active tooth infection. So it seems like they're not related, but the reality of it is any active infection anywhere in the body can cause an seeding of an implant or so. So I like people to be not on any antibiotics. I don't care what the infection is. I tell them wait until you're cured. Let's wait a few weeks after you're done with your course of antibiotics and then we'll do the procedure, because that's really it. And then outside of that, smokers. Smokers are the number one people I will not operate on. They have to quit for at least a month before and a month after. It's a non-negotiable. Those guys don't heal. The fat doesn't survive. High risk of infections. Really, the results end up being much poorer. They lose. It's the worst thing to happen for aesthetic surgery and surgery in general. It just, no one heals properly. And then finally, I was gonna say, if someone's like, they need a facelift, but they're like, oh, maybe we'll just spruce it up with a little bit of fat. I really tried to push them away from that. I'm like, look, we'll get a little bit of volume, but it's the same idea of just putting filler in there. We're not really fixing anything by adding the fat. We might as well just wait until you're ready for your facelift, and we'll fat graft at the same time.
There you go.
Yeah.
Now transitioning over to facelifts.
Okay.
I already told you what my number one question is. We want to hear your real, true, authentic thoughts and opinions around biostimulators before a facelift, because the reality is the majority of patients have had them. Would you not agree?
Yeah, probably a lot have had them. It is very common. I'm more okay with the biostimulators being used beforehand. I will say this. There tends to be a lot more scarring when we go in with anyone. I've noticed that with fillers. I think I tend to see it more with stuff like Radiesse, if I'm being honest, and definitely threads. I am absolutely not a fan of threads as both a way to get results. I think, they look great for a month or two and then they wear off. So for the amount of monetary investment, I don't think it gets them the longevity they're looking for. At least if they're only doing threads. If you're going to do threads plus fillers plus this and you're doing skincare and you combine it, maybe you can push those results. But in my hands, I used to do them. I thought they looked great the first month or two, and then I see them 6 months out. I'm like, you know what, to be honest, I don't love it, so I'm going to stop doing it. But that's not to say that you can't get good results with it. My issue with it is when we're plucking them out of the face during a facelift on threads that they told them were absorbable. So this goes back to what you were saying before, that are these things really absorbable? Like they did imaging on all these patients that had filler 10, 20 years ago. They did MRIs of their face, and they're seeing that there's still filler on them, and these were all hyaluronic acid fillers that they're seeing that on. So, I know we're calling everything absorbable for the most part, but based on the amount of threads I've pulled out of people's faces, I have to assume that to some extent our body just can't break it down, or certain people can't break it down the way others can.
Interesting. And then with Sculptra, With Sculptra, so do you tell your patients that want a facelift? Are you like, you can't get Sculptra for a year or 2 years before a facelift? Do you have rules like that in place?
I would say I won't stop them from that, but I would tell them I don't want you doing it from the time of our conversation. That's really my answer, right? If you did it already, we've done it, we really can't do much about it. If it's been in the last, few weeks, I'd say let's wait a few months just to see how the sculpture kind of develops, and then we go from there. Either way, I'm gonna want to probably add some fat into the face, so I just don't want any manipulation of the area, any increased inflammation, anything like that going into the procedure. So if, let's say, they had it 6 months, a year prior, I'd say, okay, you've had it, now we're talking about facelift, don't go backwards anymore. Now let's talk about surgical plus fat grafting. Don't now start doing other things that may affect my ability to do the procedure moving forward.
Yeah, that makes sense. Is there an age, because I do think that a lot of people are getting facelifts at younger ages now. My question is there an age that's too young? And then also, is there a maximum number of facelifts you can get through your life? So if you start younger, does that mean you're going to end up getting 3 versus 2 in your life?
Yeah, I think that comes up a lot, and I think it doesn't matter so much about your actual age. It has to do about the age of your skin in terms of how much damage you've done to it. Again, are you a smoker? Do you like the sun? All those things. I see a lot of people that are in their, let's say, late 30s, early 40s that were already talking about facelift territory. And I've also seen 80-year-olds that I'd say you're not even ready for a facelift because you just take absolutely amazing care of yourself, that it would be a waste to do one on you. So it has to do with skincare. It has to do with how they take care of themselves. Are they hydrating? All those factors that we kind of brush off all the time, that everyone's like, oh, I don't notice a difference if I'm drinking a lot of water. I'll tell you personally, I can tell the difference on a week that I've been very good at hydrating versus not. I can see my skin shining differently. I can see just the difference personally. And then the other part of that is, remind me again, you asked me one other question.
Is there a limit of facelifts? Let's say if you started when you were 35, how many are you going to need?
There's no limit, but you probably will end up needing one. So if your skin quality was at that point where you needed it relatively earlier, the chances are the factors that led to you needing a facelift earlier are going to contribute to you needing one again later on in life. Now, you could make the argument it was someone that was a smoker that quit, is no longer smoking, now they're not in the sun, now they're using skincare, they're really taking care of themselves. That'll extend the results. You can go from a 10-year result to a 20-plus result in terms of when you would need your next one. I don't like relying only on the surgery as the reason for the longevity.
Yeah, and that makes total sense. But I do think that even people that are taking good care of their skin, they just don't want to continue to inject themselves with all of this stuff for years and years and years. They're getting facelifts younger as well, and they probably have better results, better outcomes, and all of that.
The non-invasive modalities we have now, I don't personally have them in my practice, but we refer out to them all the time. You have your microneedling, your radio frequencies, lasers, all this stuff. There's so many options to help you prevent needing a facelift. There's no excuse in my mind. If you really put a little bit of effort in, you can push that facelift off. You should not be talking to me about one until you're in your late 50s, 60s in my mind, right? That's where your body really, you've done everything you can at that point where your body's like, all right, now we just need a little tightening of the muscle, we need tightening of the skin, and we lost volume, right? So I think there's so many options and so many good non-invasive options or minimally invasive options that really can help you get there without having to constantly put, fillers and other things in your face if you wanted to avoid it.
And then before we end, just another question about the business side of it. I guess what drove you to open your own practice, and what has been your biggest hurdle being a physician and owning a practice?
It's a good question. So personally, I felt I'll start off with nothing happens by yourself in my life, at least. Surrounding yourself with people that are excellent mentors that you trust, and I mean really trust. One of the most important things in life is taking advice from people that you know what they're talking about, and not just taking advice from because everyone's going to want to give you advice. And then you see what they're doing, and you're like, well, you didn't really do anything about this, but you're giving me advice. Those people I don't listen to. I listen to people that I've seen succeed. I surround my people that definitely have succeeded, whether it's in plastic surgery or business in general, right? So it doesn't have to be medicine. There's people that are in real estate that I talk to all the time, and they've guided me on how much I should spend per unit or per foot on the office, right? So things like that helped me at least with foundationally of getting into the space and doing what I had to do. The reason I went off on my own is, in my mind, whenever you're working with someone else, as much as I loved it, at the end of the day, it's their baby, their concept. You're going by their rules. You don't have as much mobility in terms of, well, I don't necessarily agree with this style, I'd like my own style. And in our world, I think both of our worlds, at the end of the day, it's all about style. Someone can love my results, another person could be like, that's not for me. So I'd like to be in control of that. And that's kind of what pushed me to go out on my own. I will say I was very, very young when I did it, and it was definitely, I was hesitant because even when I was talking about securing bank loans to build the office and stuff like that, they're like, you're probably the youngest person that's ever sat across us that's talking about this right now. So are you sure this is what you want to do? I can tell you today, I'm very happy I did that, but there's a lot of anxiety, angst, and it's continued anxiety. Anyone that owns a business understands that the better the business gets, it's not like all of a sudden the stress goes away.
No, it gets more and more and more.
Definitely gets magnified. And I think the final thing to answer your question, what's the biggest hurdle? It's people getting to know you, right? You have a lot of stress and pressure. You have a lot of overhead. It's hard to separate our world from medicine. It's a business mixed into medicine, and it's very tempting to be like, well, let me just do this procedure, even if they're not a great candidate for it. I still have to pay my staff. I still need to cover my overhead, my rent, my this, my malpractice, all that stuff. And one thing I've tried to stay true to is don't do any procedures for that side of it. Try to do it because it's absolutely the right thing, because every time we operate on someone or we even turn down someone that's not a good candidate, it has always, always, always resulted in a tenfold increase in business. They always end up telling their friends come in, they're like, oh, look, he told me not to get a surgery. Those people we've told not to get surgery have sent us patients being like, we think he's honest, he was honest, he could have easily done X, Y, and Z. I wanted him to do a facelift on me, and he said, wait, go get radiofrequency microneedling, right? And I think if you care about the patient, you're honest with them, and they feel like you're being genuine, that's the best way to build a business. Put out quality, not quantity, and it takes time. For sure it takes time, but people will start coming in.
Yeah, I 100% agree. I mean, we stand by our word. There's a limitation to non-surgical injectables for us, obviously. And I had a patient this morning that I turned away. She's a smoker, 71-year-old, all these complications. I'm like, I'm so happy you're here. Her 2 daughters were with her. And yeah, you could see the trust. Just, it was palpable because I wasn't just going to do anything to her. So I think that is really important. Obviously, very ethical and honest, and speaks to you as a person. So it's amazing. Well, thank you so much. This was awesome.
This is great.
Yeah, this was so great. Tell everybody where they can find you, contact you for consults or whatnot.
Sure. So we're located in Roslyn in Long Island in New York. For anyone that's not familiar, they can always reach out to our office. We'll tag our number, but 516-515-9267. Our Instagram is David Kashan MD. You can always message us on there. The girls are always keeping track of who's messaging, and we have a lot of people reaching out. And there's a million ways to reach us, but those are probably the 2 best ways if anyone ever has anything. And again, thank you for your time. This is actually I enjoyed this a lot. We should do.
It's so much fun. I know we should, because we didn't talk about any of the breast stuff really. So we can definitely do a part 2. Yeah, this was awesome. So thank you all so much for listening. Like, subscribe, share, and we'll see you again next time.
Awesome. Thank you, guys.